susceptible to gravity, will float around for long. Splatter is very, very susceptible to gravity. And then droplets are intermediate. So they may travel some distance before gravity affects them, depending with what size of droplets you're looking at. And then, of course, the composition. And now here is where I really want to make the difference. Splatter will have all these things, but they are huge particles. We can see where they are, and most of the time we can wipe down those surfaces, but they fall down quickly. They don't linger around long. Droplets have a lot of organic material, can float for some time and for some distance, but not too far. But they are the most infectious because they just have enough organic material. They float just enough, not too far, but enough, and they keep the virus viable. Aerosols stay around longer, and in the event you inhale them, they'll go all the way to the lower respiratory tract, but they don't have a lot of organic material, so viruses don't survive in them for too long, and they are susceptible to air movements and open environments and things like that. So that is why when people walk around, and many other factors really, and we keep talking about droplets, it's because that zone of droplets is really the most dangerous zone. That's where the virus is least susceptible to gravity. It's least susceptible to air movement. It has the most amount of organic material. So yes, you can get an infection from splatter. You can get infection through aerosols, but the most efficient way to get them is droplets, which is why even outside dentistry, we are saying masks make a big difference. Even if it's just a low quality mask, by reducing how far droplets go, which are the most infectious materials, that really, really makes a big difference. I hope I have partly answered my question, which is why I say we have to really keep focus on some of these things. So if someone sneezes, for example, the droplets go way further compared to just talking normally. But if you add a mask in front here, even if you sneeze or cough, you really have curtailed how far the droplets can go. And even if it's a low quality mask, what is likely to escape through is probably aerosols. And like we know, they are susceptible to things like moving air, and they don't have that much organic material. So the virus might even be there, yes, but it's not that viable. So this is some of the things that I think from a public health standpoint, we have to keep our eyes and target on them as the risk increases. So what is the specific risk as I finish in dental settings? There has been consistent detection of the virus in saliva. And if you check around the internet, just Google oral DNA. This is a company that's just coming up, and I think they've just been given emergency use authorization test that is based on saliva, because the virus is consistently found in saliva. Where does it come from? Maybe it's from the upper respiratory tract. Maybe it's from the major and minor salivary glands. Maybe it's through the gingival clavicular fluid. Not known, but we know that the virus is isolated in saliva, and therefore the place we work, the mouth, definitely has the virus. So what is unique about us? One, we work close to the airway, which is the one tissue that has all the trifactor. It has the right proteins, it has the right receptors, and it's exposed to the outside environment. So it gets the droplets and the aerosols and the splatter. So it's the perfect storm, and we work very close to that place. The nature of our job is we generate all categories of particles. We generate splatter, we generate droplets, and we generate aerosols. Again, unlike someone walking down the street who's probably facing the biggest risk from droplets, we face the risk from all these things. And then increased risk of fomite spread. Our patients, things will drop from our patients into our office. We tend to work in small offices. Most people, I suspect, that also holds true in Uganda. And those surfaces, if not cleaned, can be a place of inoculation. But we also have certain positive uniqueness. One, compare yourself to your medic friends. You've been putting on a mask routinely compared to medics. We have a good culture of putting on gloves. Medics try to put on lines and examine patients, do auscultation and percussion of the patients with no gloves. So we have that culture. We have a culture of wiping down between patients. We have a culture of having autoclaves in our office. We have a culture of using a lot of disposable things. So these are strengths that we have as a profession, and therefore it's easier to talk to dentists about infection control. It's easier to talk to dentists about how to clean surfaces. Our assistants in our office already wipe down surfaces and things like that. And truly, it's easy for us to sterilize things and to put on masks for long periods. We've been doing this. So do we have a higher than normal risk? There's no data to show we do, but the New York Times published a very interesting thing on which workers, which careers face there. And if you look at the top there, right there, Dentists are there, and I can tell you hygienists were higher than dentists. So it is thought we have high risk. And the reason is simple. We work close to the airways. We generate droplets, splatter, and aerosols. We work in small rooms, and we work in the mouth. It's just the perfect storm. We face this risk together with the ENT surgeons, anesthesiologists due to intubation, but also think about flight attendants, closed areas, close quarters working. So these are all the risks we face. But there's no substantive data really to show that we have a higher than normal risk. I know I am involved in some study. We just yet to get ethical approval with the KDA, and we are going to try using the ELISA test developed by Cambridge to see what is the rate of antibodies against COVID-19 among dentists, and we try and compare that to the general public and see, do we have higher than normal? And so hopefully we'll see how that goes. And this might be the reason why the WHO a few days ago gave out some guidelines for dentists. And I'll tell you, this has generated a big storm. I strongly advise, you can get this freely from the WHO website. Read it and compare with the guidelines that your country has given. There are some things to love here. There are some things to dislike. They've given certain things, and they've encouraged us to postpone a lot of procedures. What I find very interesting is their definition of what an aerosol generating procedure is. Now pause there and think for a sec. Aerosol generating procedure. What's an aerosol? Is it only the small things? So we're not worried about droplets anymore. So I think I want to encourage people to just talk about particle generating procedures, and that covers everything from splatter to droplets to aerosols, but that's just my own thing. But picking from this WHO publication that just came out recently, and I'm just picking that box there, they define an aerosol generating procedure in dentistry as all clinical procedures that use spray generating equipment, such as three-way syringe. So pretty much everything we do. Dental cleaning with ultrasonic scaler and polishing, majority of the work we do. Periodontal treatment with ultrasonic scalers. Any kind of dental preparation with high or low speed handpieces, direct and indirect restoration and polishing, definitive cementation of a crown or bridge, mechanical endodontic treatment, surgical tooth extraction, and implant placement. Pretty much everything we do in the view of the WHO is aerosol generating. And that tells you the risk we face. Now, stick with the word aerosol now. Aerosols are less than 50 microns. What kind of mask are you using in your practice? A surgical mask is useless against aerosols. It works for droplets. It's useful for splatter if it's water resistant, but it makes no sense for aerosols. So one thing, and this is just my own speculation, that I see the legacy of dentistry, we're going to move away from surgical masks to the N95 variety for the rest of our careers. Same way HIV changed how dentistry is practiced, this might be the one thing that changes. So I hope by now you're using N95, which is just a standard developed by the National Institute of Occupational Safety and Health in the US. The Chinese have KN95, and the Europeans use FFP2 standardization. So any of those masks are equivalent. And I hope that's what you're starting to get. They are very hard to get. The price has shot very high in Kenya right now. I don't know about Uganda. And there's a lot of fake ones around. So I hope at the very least that's the mask you're using while you're seeing your patients. Of course, the guidelines from the WHO started a firestorm, and people are saying the WHO is being too generous in its definition. The ADA doesn't agree with them, and my favorite association on earth, the American Academy of Periodontology, also says they don't want those guidelines. So I don't know what the Kenya Dental Association will have to say about that. We have some meeting to read and digest that. I don't know what the Rwandan Dental Association has to say, and as sure as hell, I don't know also what the Uganda Dental Association has to say. But we need to take a position on some of these things, because these things involve our careers, our money, and our patients. So we shouldn't just agree when the WHO says we should postpone all things indefinitely. I mean, we have to make a living, and what might be a minor problem for a patient today might be a big problem for a patient in the next few weeks, if not taken care of today. Just to go slightly off topic, you need to start classifying your patients as emergencies, meaning there's direct threat of death. Urgencies, which means things that might get bad but need to be taken care of. So emergencies and urgencies for sure have to be treated. And then there's what we call routine care. And routine care is where there's big debate. Should we postpone or should we continue seeing? Anyway, if we choose to work, we should limit exposure, which means protect everyone. Assume everyone has this thing, because like I said in the introductory slide, there is a lot of asymptomatic patients. And then limit contagion, which is the actual getting of the virus. And for this, we have to look at the infection control model. So this is a slide that I've been using to teach my undergrads for maybe 5-6 years, maybe modified for purposes of COVID, but it's the same slide in principle, modified from the CDC that published it probably 20 years ago. There's normally a pathogen. So we typically used to worry about HIV, hepatitis, Mycobacterium tuberculosis, and where it's coming from. So there's a guy coughing, spreading around TB. There's an HIV positive patient. There's an HIV positive instrument. So it has picked blood, maybe a sharp needle or something. So there is a source for that pathogen. And then the mode of transmission. So we, like in this case, we've talked about droplets and aerosols, but other things require direct inoculation into the bloodstream, like HIV or sexually transmitted or vertical transmission. And the mode of infection is always looked together with the portal of entry. So does this condition get you through the skin, through mucous membrane, through sexual encounter, or all of them? Now we know for SARS-CoV-2 is mostly the mucous membrane of the nose, the mucous membrane of the mouth, and possibly through the eyes. So those are the three big things. Now, even if you touch it with your hand and everything, the risk is that you will eventually transmit that to your mouth and nose by touching or moving from the surface, not that it will go through the skin. And if all this happens, then you have a susceptible host. So if you're susceptible to this condition, then you get, and that from here onwards, the clinical course will really come down to patient individual factors. So let's see at every step of this what we can do, and then we finish this presentation. What can we do about the pathogen? Now, typically, if you know a surface has TB or something, what do? If it's a person, you treat them. If it's a surface, we sterilize our instruments, we disinfect them. So these are some things we do about pathogens to get rid of the pathogen. What can we do about SARS-CoV-2? Right now, we are saying there's no treatment for it. So if someone has it, there's no way of eradicating the virus from them, except depending on immunity to eradicate it. We can use alcohol-based sanitizers for fomites, for our hands, isopropyl, povidone iodine, and wash our hands and clean these things. This can eradicate the pathogen. Soap, and I particularly want to if you remember the proteins I showed you, there's a lot of glycoproteinaceous. Any soap, even if it's counterfeit, unlike the other products, even counterfeit soap, so long as it has a surfactant, will destroy the virus. So I want to encourage people to wash hands, wash surfaces, clean things that can be cleaned with soap, dip things in soap. This will help with fomite strength. We can also do something about the pathogen by having high suction and evacuation to get rid of aerosols and droplets from the environment. So we're getting rid of the pathogen. The source, there's not much you can do. If we know you have the condition, then we isolate you. That's why people have been talking about the isolation. If we suspect you've had contact with it and we don't know yet, we quarantine you and then we test. So if we find it's positive, then you go into isolation. If we find it's negative, then you go into proper behavior and we treat you normally. And what can we do about this? We can only hope there are government regulations for people to follow rules when they are infected. We can educate the public, engage in such things as we're doing now, and hope that people have personal responsibility. The mode of transmission in the portal of entry is really, unfortunately, what we are talking about all the time. And here we can only do barrier methods. Quote my lips, PPE, that is the new buzzword in Kenya, personal protective equipment. That's the best we can do for the portal of entry as we have understood which areas this is. So we can use our gloves and masks and gowns and face shields. But then the susceptible host, how do you make it? The government of Kenya says if you're above 58 years of age, you shouldn't go to work if you work for the government. So lecturers above 58 are not showing up anywhere near universities because we think they are at higher risk. And so that's what we are doing. The other thing we can do, remember for dentists, we used to say all dentists must be vaccinated against hepatitis. We were just making sure we are not susceptible hosts. So even if the sterilization fails, even if we don't isolate the person, even if we don't put on gloves, at the very least, we are not susceptible. Now, for this condition, there's no vaccination yet that we know of. Are some people having acquired immunity? Possibly. The first few weeks after you get an infection, you basically have acquired immunity. But how long does it last? We don't know. Do some people have natural immunity that they just can't catch this thing? Again, not known, but it's possible that some people have T-cell immunity to these things and they won't ever get it. So if we could figure out who those people are, then they would not be susceptible hosts. We could allow them to go back to you. So as yet, we don't have a vaccine to minimize susceptible hosts. We do not know if infection with the disease confers you lifelong immunity or for how long. And it's not clear that natural immunity exists. So we have to really stick with the other things, modify our behavior, use PPE, and things like that. So in finishing, the PPE is really a discussion that has been there for many years whenever there's a pandemic. But people have talked about all these things. People are dressing in all sorts of ways. But personal protective equipment is a concept that is very old. If you are into motorbikes, you use personal protective equipment, helmets, spine guards, knee pads. So these are things that are there, especially in the construction industry. If you use a hard hat, so they have always been there. So, but Corona has really made it to be talked about too much. You don't have to get anything dramatic, but we have to discuss what some of these things are. That image amazed me some times back. And this is not what we mean when we say PPE. So I want us to get one thing. Yes, this is part of PPE, but it doesn't mean we should all dress like this. That's not what it means. So this afternoon, I harassed my my assistant just before they left the office when I was preparing for this to take some pictures of them and show what levels of PPE we can do. But before we go there, I want us to engage in what we call system thinking. And for a second, just disregard COVID-19. When you start talking about workplace safety, you first need to work on eliminating the danger, okay? Elimination, that's the first thing at the top there. And that's what you should do. Stay away from things that are dangerous. So if it's a motorbike, you think it's dangerous, instead of buying all that helmets and things, you can just stop the habit. In dentistry, we still have to see our patients. We can't refuse, so we can't eliminate it completely. Substitute, we can't do that in our case, but we can isolate those people we suspect. Hopefully at some point we get a rapid test, so a patient reaches your door, you test them. Those who are positive, you tell them, okay, be seen at different time. Those who are negative come in. These are things we can do. But we can also do engineering controls. Now, I can tell you, and Dr. Kizito will tell you, there's been a lot of work going on in dental school. There's a big new suction apparatus that has been installed. I know a lot of my colleagues here in Nairobi have bought HEPA filters and put them in their offices to try and clean up the air. So we can change some things. I am in the process of changing the taps in my office from the ones that I used to use to roll around, and I want to go on the ones that I use my elbow to close. These are things you can change. Then you can change administrative controls, rotate people in shifts, change how you work online and such things whenever possible. Our job, we can't do that, but you can change your reception and now spread aside the chairs so that nobody is sitting next to another one. Tell your assistants not to give out pens for people to fill things, and maybe start verbally talking to the patients. These are things, and stop receiving cash and move to cashless systems or systems that depend on like mobile payment. And when all this is in place, then now when you have to deal with people directly, that's when the discussion on PPE suffices. So I want people to think globally, not just localize yourself to the PPE. This particular slide was not necessarily meant for this presentation, but I am just talking something about the N95 mask, which is really supposed to be the standard if you're seeing patients right now. And an N95 that doesn't have a respirator, because if it has a respirator, it protects you, yes, but in the event you're the one giving out the disease, then it's still going out. So I took a picture of my assistant today. Typically when she goes home, she will dress like that because she's going to be walking outside and she's not interacting with anyone. So a surgical mask would suffice. If you choose to engage in N95 masks, one thing I just want to warn you, and I'm not paid by 3M, but I think it's necessary to really understand this. There's a lot of fake masks out there. So check out for that mark of safeguard, and there's a code they put there for you to check that you're buying the right thing. And these things are so expensive right now, and it shouldn't have a respirator. And don't buy anything that has ear loops if it's an N95. You have to get pressure so that it completely forms a seal around you. So it has to have rubber bands that hold back the lower one at the base of your neck and the upper one at the crown of your head, so that it's really fitting very well. Now that particular mask that lady is putting on is too big for her, so she needs to put on the medium or the small size so that it adapts very well to her face. And then we are using face masks in our office. People have to use these, and they have to cover their hair because women and their hair, and me too, I like touching my head. You must have noticed that a few times. So these are important things to do, and typically we want people dressing like this. The important thing to say about the gown is it should go to the neck. And this just helps you when you want to leave the office. Remove this hygienically, drop everything in the sealed waste paper bags, and you wash your hands and everything, and you can go home safely. And with some certainty you can know that yourself. Just to give you some information, I saw a patient last Saturday who we were informed on Monday the patient has tested positive for COVID. And I mean, we just, my entire staff and everyone had tests done on Wednesday, and we got our results yesterday afternoon. And everyone is negative, but I suspect it's because we dressed like this. I don't know, or maybe there's just not enough viral load, or maybe the patient wasn't shedding virus, or maybe we were lucky, but we did a pretty long procedure. So we were with the patient for a long time. So these things are real. So I'd like to stop there, and hopefully I've given you enough information to help you start thinking about this differently. Typically, the next series of class after I do this would normally look at how to don and doff and remove these things, the sequence of putting them on, and how to take care of patient, how to use high volume suction and things like that. But I think we don't have the time to go into that. Thank you very much, and receive my hugs over the internet. Thank you, Dr. Kizito, for inviting me for this.
Okay, thank you so much, Dr. Alumera, for the wonderful presentation, and right on time, right an hour. So I want us to use the next 15 or so minutes just to have any concerns, or whoever has any questions to be addressed by Dr. Alumera. I'm so happy that this is actually a UDA arrangement, but when I had this presentation the first time from Dr. Alumera, I thought that it would be good for us, or a little bit of a bigger audience, to listen to. So it's a good presentation. I am looking at some of the questions or concerns from the group chat. If there's anyone who has a concern or any question, an appreciation or anything, then just post it in the chat. All of you are muted because we don't want any interferences. I'm going to start. There's one, most of the people are thanking you so much for the presentation, that it's very informative, that's almost everyone, Dr. Semakula, Dr. Kalisubula. There's one question that was asked by Dr. Kathy, who was asking that you talked about 2 strains of the virus, of the coronavirus of 2019. But then of what importance is that in terms of effectivity or severity of infection? But she's also thanking you so much for the presentation. I guess we can answer one at a time. That's the only one that is there now as we go on with the presentation. Dr. Alumera?
Okay, yeah, thank you very much. Like I said, I don't want to use the word strain. I know I get what you're asking, but strain normally means quite a major shift in a microorganism's behavior. So let's think of this as we like to use 2 words in when you're looking at microbiological ecologies: wild type and a mutant. So what is common out there is normally called wild type. That's what's the majority. And then when one deviates a bit and you have a slight change in mutation, but it's still the same species, then you call that a mutant. But sometimes the mutants become the majority, and therefore it moves and shifts. It's called the wild type. So, and then the other one now, it sort of fades, or you can also say we have 2 wild types out there. So what I was trying to say is there's been a shift, and the WHO, the CDC have been tracking this. And now the one that has a G614 is the most common mutation that occurred and is popular. It's way more infectious, much more efficient at infecting people, but the percentage of people, or the number of people who get severe symptoms, is slightly lower. So just to put it oversimplified, it's less dangerous clinically, but it's a bigger problem in terms of public health. It's more infectious compared to the earlier one, which was harder to transmit, but on the other hand, was causing more severe disease. So that's what's been noted. Again, these things are updated frequently. There are people really constantly monitoring them, and we have to see. The only thing to keep in mind is majority of the people who are positive for COVID-19 are not known. Okay, so we can only base that on those we know. And so sometimes that might actually be fooling us. Maybe all those people we don't know about have some other variant that is very, very mild and we never know about it. So that's me just speculating, but those are the possibilities.
Okay, thank you so much. So the other question is coming from Dr. Lalani, who is asking, thanking you so much also for the presentation, but she's they're asking about, number one, does the SE affect the flow of aerosols? And then number two, does spraying a sanitizer have any help after a patient has left?
Okay, good. So those questions are actually part of the same question. Let's introduce some terms here. You may have heard of HEPA filters, and these are just things that pull air in one direction, and they can filter very small particles and basically, in quotes, purify the air. There may be value in using such things. Now, like I said earlier, aerosols are a double-edged sword. One, it's not a conducive environment for the virus to stay viable for too long. On the other hand, aerosols, when you inhale them, they don't just stick in your airways. They go right into your alveoli because they are very tiny. So they may actually cause lower respiratory disease pretty quickly if you inhale them in sufficient doses. Now, spraying something in the air is actually something, there's a machine that is selling like hotcake in Kenya that people are spraying in the air. And I don't want to interfere with someone's business, but the truth is that just doesn't make sense. Remember, to kill any organism, even if you're just thinking about day-to-day work, you require time, concentration. So the chemical you're using has to have the right concentration that affects that organism, but then you require some time. When you spray something in the air, and you can see that mist, that's because the particles are big. It settles on the floor pretty quickly. Hopefully it will kill some, but does the interaction with the aerosol happen so much? Maybe not. So if you're worried about aerosols, you need to be thinking about laminar airflow. That's why you may have heard in social circles, we say being outside is better than being inside because of the circulation of the air. So if aerosols is your biggest concern, then have a clinic with big windows. Now, your clinic is your clinic as it is right now. Maybe if it's not very spacious, it doesn't have big windows, the best thing you can do is to create laminar flow, put an air evacuator so that all the air is being pulled in one direction. One of the other things you can do if you have space and you have two rooms is to exchange which room you're using so that naturally the aerosols are moving towards outside. Remember, the tendency of air in any room, especially in the tropics, is to move outside. It's to move outside because it's getting warmer inside, and therefore the air is more fluid on the inside than outside, so it moves outside. Unlike in temperate areas, sometimes that depends with how humid it is outside. So aerosols are a big deal. They're difficult to say, but I said in terms of protecting yourself, the best you can do is to use an N95 mask, you and your staff. Now, just to go slightly with that, N95 masks, like I said, are very expensive. So what we are doing in our office, and a lot of dentists in Kenya are doing, is you put on one N95 in the morning when you come in to start your session, and you put surgical masks on top of that. And that's just to prevent the splatter and everything to go on it. And therefore you keep changing the surgical masks between patients and hopefully keep that N95 till maybe you see 3-4 patients at the end of the day, then you can discard it. There are some manuals that have been put in officially by the American government and a few people on how to sterilize N95s. I would encourage you to look at them. And the reason is they're scarce and they're very expensive right now. We are buying one N95 in Kenya right now for about 1,500 Kenya shillings. And you can imagine if you're seeing patients, that's a big deal. And that would bring in even a debate I would rather not get into is, should we charge patients for these PPEs that we are using? The government of Kenya has just announced today that public hospitals start charging for PPE. So I think that has just opened the door for all of us in private practice to also charge our patients. So these are some of the issues that come up. So the aerosol debate, I can tell you, anybody who gives you a direct answer, it's yes or no, is probably wrong. There's a lot that remains to be seen, and there's a lot of work in that area. Droplets, we know. Splatter, we know.
Okay, thank you so much, Dr. Alumera. So the next question comes from John Paul, who is asking about the immunity. He's asking about reinfection, I guess with what's going on right now, about the acquired immunity from the infection from COVID-19. And then that's number one. Number two, I'll just double these questions together. It's also asking about the use of disinfectants. What's the contact time and for average disinfection of the surfaces in order to assure the surface is free of the virus?
Okay, I'll deal with the issue of reinfection. All the reinfection we've seen is anecdotal. Now, that's not to say it doesn't happen, but remember, case reports, how much evidence do you attach to them? So there's been anecdotal reports of reinfection. Now, things to put in mind before I comment on that. One, the RT-PCR test, which is the gold standard, has about 70 to 75% sensitivity. So it's possible that it can miss something. There has been a debate in Kenya, and I suspect in Uganda as well. The private labs are doing a test that checks for 3 genomes of the virus. The government test checks for only 2. So if you have the third genome, you probably are being told you're negative by the government, then you go to the private lab and you get positive. So some of these so-called reinfections, it might just have been what is wrong with the test, a false positive or a false negative. It's possible. Having said that, it is now a settled matter that after you get an infection, you develop some antibodies. That's a fact. The big issue is, how long do you keep those antibodies that have been developed? I have seen estimates from about 3 months to 4 months, but at least everybody agrees that the concentration of those neutralizing antibodies drops rapidly after you get better. So we don't think from the antibody perspective, you keep them for long. However, immunity is not just about antibodies. People seem to also develop T cells, and T cells, remember, can quickly start producing antibodies or identify cells if a reinfection occurs. So the T cell immunity is what's now being investigated. That might be the pathway for the long term. And I would give the example of the common cold. The common cold, when you get a certain strain for the first time, you tend to have a really bad cold. You may still catch the same cold, but it will be very mild. But there are no antibodies for that cold. What has happened is your T cells have been sensitized to it. And the next time you get the same infection, they quickly mobilize. So it's like knowing which part of the city is dangerous and putting policemen. It hasn't solved the problem, but the response will be faster. So the issue of immunity, one, it's not clear whether it's long-term, but two, it might be through T cell. It remains unknown. Turning to the issue of disinfectants, how long? Let me start with the first thing. People are telling you, ask the patient to rinse the mouth. Now, traditionally, I'm a periodontist, and we've been doing a lot of chlorhexidine rinses for our patients. Now, chlorhexidine has minimal to no antiviral activity, generally speaking, not necessarily against SARS-CoV-2. So it doesn't do very well against viruses. So shift your pre-rinse to povidone iodine based or hydrogen peroxide. Now that comes with some downsides. If you want to do your beautiful composites on anterior teeth and then you ask your patient to start rinsing with povidone iodine, you will see how that works for your color matching. Same thing with hydrogen peroxide. It has some little bit of a bleaching effect, and that bubbling makes you sometimes unable to see things. So those are downsides to these things, and you have to think about that. One of the things we do is you have to, all of them require at least 15 seconds, but because of the effectiveness of the patient swishing around, you want to encourage them to do it for 30 seconds. So what I know we do is we do 30 seconds of povidone iodine, wait for about 20 seconds, and then with a rinse with water or something if you want to do a procedure that is sensitive to that. If I'm doing something else, then I don't have to do the rinsing with water. But those are the challenges you'll face. For surfaces, alcohol-based rubs for 20 seconds do. Now remember, you want an alcohol, so this is isopropyl or ethanol, at least 70%, but preferably something that has some glycerin or another base added, simply because alcohol on its own evaporates too fast before it has contact. So if you've used a hand sanitizer, for example, has a bit of that glycerin effect, it's much better because it stays on the surface slightly longer than something that is just pure, very aqueous, in the aqueous state. So that's something. But for alcohol-based rubs, you're looking at about 20 seconds for cleaning the surfaces. Now, the air, whether you can sterilize the air or clean it is really just difficult to say.
All right. I think just as a follow-up question, there's Dr. Mayanja is asking, what is or how effective is UV light on disinfection of surgeries? Before we go to the next question, actually, because it's the same.
Okay. The UV light. So UV light destroys bacterial cell walls, destroys viral coats. That's a known thing. But now I like giving this example. Sorry, I'll be a bit off topic just so that I explain this. Phenytoin sodium causes gingival overgrowth. But you don't go around prescribing phenytoin for people who have gingival recession so that you cause overgrowth. Because things sometimes that are mechanistic, that make sense, don't necessarily in practice work that way. So UV light in a small box, and if you put something, will destroy bacteria. The problem is most things are not regularly shaped. So if you light UV light in your office, any place where the UV light is in enough contact with microorganisms, it will cause their death. But what about the areas where light cannot penetrate? Remember, light travels in straight lines only. So you find that it might not necessarily be a good solution for clinic-wide sterilization. It may make sense for little things like, if you have a small box to put your phone inside there, or if to put something tiny inside there, that makes sense. So you may use it that way. So And this generally is something that happens to all disinfectants. There's no perfect disinfectant. So you have to use different things. You have to clean your instrument and then use a disinfectant and then put it in an autoclave. So the more layers you use, so I don't mind if you have some UV light that you leave on overnight or something, so long as you keep in mind some materials are destroyed by UV. But you have to have another layer. So if you combine alcohol, if you cover your surfaces with disposable stickers and things like that, and if you maintain good hygiene generally, so those, it's many layers, not one thing solving all your problems.
All right, I'll ask the last two questions. One is from Dr. Lalani, who is asking how whether the usual flu shot can help in the immunity. I guess that's from the information that we're getting currently. The other one was from Dr. Mbabali, who is asking the relation, or if there are any risk of transmission through local food, because there's read of some reports of COVID-19 from chickens. That would be the question.
Okay, good. I'll start with Dr. Mbabali's question. Dr. Mbabali, hi, it's been a while since we talked. Remember, I talked about fomite spread. So when we're talking about foods, of course, there's the packaging and things like that. Fomite spread is not easy. It can happen, but it's not easy. It's just difficult because the virus is also quite fragile. That's one thing to keep in mind. Now, I have seen the reports about chicken being infected in China. Now, the test that was done was a PCR test. And as Mbabali, you may know, because I know you did molecular biology, all they do is they're checking for primers of the genomic sequence of that virus. Now, is it viable? Can it actually cause an infection? That remains to be unseen. So that bit is not solved. So I cannot give you a definitive yes or no, but generally what we know is fomite spread is very low. It's not the biggest way to spread. And whether the virus that they're testing for is viable, I don't know. Now to the issue of the flu shot, I want to start by talking about science generally. What the problem with pseudoscience nowadays is they tend to really use Facebook and Twitter and all these things, and they're quite effective. And sometimes science behooves us to question some things we see. Everything in life regresses to the mean. So if you just took some random food and gave people with COVID, half of them will feel better. So that is just regressing to the mean. Now, does the flu shot work? It's possible. Why is it possible? Because they target the same types of proteins. They are some of the most common flus are caused by some types of coronavirus. So that is a possibility. Or the fact that you're just in a hyper immunological state can help. But the best way to prove this is to do a randomized control trial, or at the very least to do a long-term longitudinal study. Anecdotal observation that I got the flu shot and I didn't get this thing in a disease that we don't know how it affects people can be dangerous because it can give us a false sense of security. So I'm just saying, from a mechanistic argument, and I've seen those arguments, it makes sense to imagine that you get some protection from it, but we would have to test this again in a properly designed randomized control trial to give a definitive yes, no, or maybe. So it's not an easy thing. And I think along the same line, even if you talk about therapeutics, that's the same problem we're facing. You need to have a randomized control trial to answer the question, definitely.
Okay, last question before I let Dr. Alumera go. Dr. Betsy is thanking you so much for the presentation. He's asking about your take on disposable gloves and surgical gloves for cases at the time.
Okay, good. So my use of disposable and surgical gloves has not changed. Remember, gloves are protective of you. Surgical gloves are important when you're going to do something invasive. So because they're sterile, and you say, for example, you're lifting a flap, you're going to touch a bone or something like that, you don't want to transmit the gloves that are not sterile. Having said that, if I'm just examining a patient or if I'm doing a surface thing, you know, like scaling and things, I'm still using examination gloves. When I'm doing implants or periodontal surgery, I use surgical gloves. And so my practice of whether to use surgical or examination gloves has not been changed by COVID. I still use following the protocol I had. The only thing I've changed, as you may see, anyone will tell you, I'm always putting on scrubs for a long time, and I feel very comfortable with them. So the only thing I've changed is now I'm putting on a surgical gown for everything. and then that's not too comfortable for me when I'm doing regular things. I don't like that, but it's there. Something else to add on: when you're purchasing surgical gowns, for those of you who work in hospital environments, the code you want to look for is called GS. So there's GS 70, 90. So this tells you whether the surgical gowns comes already sterile or not, as you would see, for example, just to give the example of gloves. It also tells you whether it's waterproof or it can soak water, so then you know what to do. And I know Kenya has authorized some people to manufacture surgical gowns that are washable now. They can be washed and disinfected. So this is just to help reduce the cost. So that GS standard is what you want to look, whether it's GS 40, 50, which are non-sterile, but waterproof, and then you go to the GS 70s and 90s, which are sterile, and then slightly thicker, and they must have sleeves at the end. Thank you very much.
All right, thank you so much, Dr. Alumera. One last concern on my side was you talked about the masks with respirators and the ones without. Is it possible to just explain the rationale? Of course, I know, but of course, you just perused through it. So just before I let you go, just a personal ask.
Okay, good. No problem. The ones with the respirator, basically, people find them more comfortable simply because masks are filtering a lot of things, and for some people, it's a feeling. You're not going to suffocate, but you feel like you're suffocating, and that especially is when you breathe out, because there's a higher concentration of the exhaled gases there. So for a second, you almost feel. So if you have a respirator, it blows the air out, and it feels much more comfortable. So those things have a one-way valve inside there. So what it means basically is when you take the air in, it's filtered. But when you breathe out, you're releasing some of, if you have aerosols and things like that, they are going out. And if you are infected, then that's risky for the other people. Which is why if you're going like in an ICU environment, if you're going to a place where you're going to infect other, you can potentially cause the infection, then the respirator becomes dangerous. But if you're sure you're negative, then protecting yourself by using an N95 with everything, so it's safe for you, it's just dangerous for other people. But I think as a general rule, because we don't know who is symptomatic and not, it's good to try and get the ones without a respirator. If you can get them. You can also improve their safety slightly by adding a surgical mask on top, so then you're not blowing out everything. Thank you.
All right, thank you so much, Dr. Alumera, and thank you everyone who has attended. I hope this was very informative. And if there's any questions, I think Dr. Alumera, even through the UDA WhatsApp profile or WhatsApp group, we can ask them, and then I can directly send them to him. Thank you so much. It's 7:30, so I'll just let you go, and then I'll meet you next time we have CPD. Thank you so much, everyone, and have a good night.
Thank you very much. Let me rush home before our curfew begins.
All right. Bye-bye.
Thanks.